Well, first of all, thank you for the opportunity to come and chat with you today. This will be a brief presentation, and hopefully whet your appetite for other things. We'd be glad to come back and provide more detail in the future, but let's see what we've got here. I work at a place called the New Mexico Tumor Registry, which I will tell you a little bit more about. Today, for this presentation, I want to cover these things. I want to tell you a little bit about who we are and what work we do, how we do that work. I'm going to show some very simple statistics about how we report cancer. So before I do that, I want to go through what those statistics are so that we can all be on the same page as to what we're looking at. I'll actually present a handful of rates for cancer in northern New Mexico so that we can see what the burden of cancer is here. We've also assembled some statistics for non-northern New Mexico, all the other counties combined. So you can see how our rates here in northern New Mexico compare to other parts of the state. Have some time, hopefully, for some questions and maybe concluding remarks at the end of that. So we spend an awful lot of time and money traveling the state, collecting information on all new cancer cases that are diagnosed in the state. We've been doing that now since about 1966. And I'm not sure why we do it. Why do I say that? Because, well, I can put it in perspective for you right now. How many of you guys, I want you to raise your hands, how many people know somebody who has West Nile virus? Raise your hand. So we got 1, 2 people. How many people know somebody who's had hantavirus? Got 2, 3 people. How many people know somebody who has cancer? Okay, so cancer is one of the leading causes of sickness and death in the state. Not only in New Mexico, but in every state in the United States. Not only in the United States, but in much of the world. And you can see that we've, I don't know how many articles you've read about cancer in the newspaper, but you've probably read quite a few about hantavirus and about West Nile virus. But these things pale in comparison to how much cancer there is. But a little bit of an introduction to show you that cancer is really one of the leading causes of death. It's and of disease. 1 in 2 people in the 1 in 2 men in the United States today, who, if you had a group of people just born today, newborns today, 1 in 2 of those boy babies will probably develop cancer in their lifetime. 1 in 3 of the girl babies will probably develop cancer in their lifetime. So the New Mexico Tumor Registry goes around the state. We're a population-based registry, which means that we're charged with looking at cancer in a defined population. Our population is within the people who live within the geographic boundaries of New Mexico. As I said before, we were established in 1966. We cover the state. We also have worked for several years with our colleagues in Arizona to cover the Native American populations in Arizona, because there hasn't always been an Arizona cancer registry. So 2 or 3 decades ago, when people were interested in monitoring cancer in native populations, the New Mexico Tumor Registry metastasized, if you will, went up to the state of Arizona and collected data over there as well. Today we work very closely with that registry, which was started sort of in the mid-1980s. We're also a founding member of the National Cancer Institute Surveillance, Epidemiology, and End Results Program, which is really the nation's longest standing program for monitoring cancer occurrence. The data we're going to look at today are largely our incidence rates. And this is, you can think of a rate, much like those of you who studied physics would think of something with regard to speed. We're looking at how quickly people are moving from a non-disease state to a disease state, how fast that happens. And you can count that. You can count how many cancer cases there are. But sometimes counting isn't enough. If I told you that there were 10 cases of cancer down in Milwaukee, and I told you that there were 10 cases of the same cancer in Albuquerque, you'd do the math pretty quickly in your head and realize that there was a problem in Milwaukee and probably not in Albuquerque. Because Milwaukee has several thousand residents, Albuquerque has several 100,000 residents. So part of what an incidence rate does is to put us a per capita spin on this. So when we look at incidence rates, we're looking at how quickly new disease is occurring. We're also taking into account how fast the disease is occurring within the size of the population, right? So when I'm showing you rates for northern New Mexico compared to other parts, we're taking into account the fact that there's a different size population in northern New Mexico than the rest of the state. Okay, so we'll be looking at the time period, the first decade of this new millennium. One last thing, it's not magic, but we do a statistical thing called age adjusting. And that has to do with the fact that in our populations in New Mexico, for example, Anglos like me, Hispanics or Native Americans, these populations have very different age structures. There's a lot more old white guys than there are old Indian guys in the state. There's a lot more proportionally young Hispanics in the state than there are Anglos. And so we do this age adjustment procedure so that, again, we can compare these groups. So these incidence rates help us to take into account how quickly the disease is occurring, takes into account the population sizes that we might be comparing. But this age adjustment procedure also takes into account that these groups that we're going to compare today have very different age structures. Okay? We also, on some of these graphs, are going to have a 95% confidence interval, which just lets us get a sense that when you're calculating these incidence rates, that there's going to be some variation. And the wider these intervals are, I'll point them out to you when I get them up on the screen here, the wider they are, we're a little bit less certain about whether that rate is as precise as we'd like. If the confidence interval is really quite close to the measure, we think that there's not a lot of variability in that. We probably have a closer measure of what's really going on with that. Okay? So the 4 counties that we looked at for this presentation are Rio Arriba, Taos, Los Alamos, and Santa Fe. And there's a couple of reasons why we did that. A lot of people, we get lots of phone calls about people who are concerned about cancer in Los Alamos. And over the last 30 or 40 years, when people have responded to these questions, a lot of times they've focused on Los Alamos. Well, that's kind of silly, isn't it? Because if there's some sort of an environmental thing going on, if there's some sort of something going on, I'm guessing that ion doesn't stop at the border of Los Alamos County and not affect other people. I'm guessing that there's even people right down here in Espanola that drive up the hill and work in Los Alamos. So probably a better strategy to give us a better idea of what's going on is to look at a regional strategy. So we're looking at all of these counties together. We certainly can, if you'd like to, take a look at each of these individual counties, but for today, I've just sort of assembled them all together, and we'll take a look and see what the cancer patterns look like. Okay, so I don't like to present this particular slide, but I did it anyway, against my better judgment. The reason I don't like to present an all cancers combined is because cancer is not a single disease. To the best of our current knowledge, there are over 100 different kinds of diseases. And these cancers are caused by different things, usually. They're treated differently. They are different disease entities. Now, it's true, there are some cancers that share causes. There are some cancers that are treated the same. But it really doesn't do us a lot of good to consider all cancers combined for most purposes. But to start this discussion out, I thought I would go ahead and do this. So the dark bars here, I don't know why this isn't projecting better than this, but the dark bars here, the solid bar, is the rate in northern New Mexico. So let me just come over here. I wish I could borrow Heidi's little stick. But in fact, I bought a laser pointer. Because we are in the 21st century. We're not, this is what we used when I was in school. So anyway. That's right. Well, and I'm going to lose this too. You know, that's what's going to happen. So anyway, let's take a quick look here at what we're looking at. We've talked about these rates, so you have some sense of what I'm talking about. This is like a per capita speed at how quickly cancer is happening. Obviously, the higher the bar, the more there is. And we would be looking for differences between northern New Mexico, the dark filled-in bar, and other New Mexico counties. This is all other New Mexico counties combined. The rate per 100,000 here is expressed, I've got 100, 200, 300, 400, 500. So typically the rate for cancer around the United States is probably in the vicinity of 400 to 500 per 100,000 per year. And that's what we're looking at here. Well, a couple of things. My eye is drawn to a couple of things when I look at this graph. In the first place, I've chosen not to just show you the counties aggregate. I've chosen to show you non-Hispanic whites, whiteys like me, okay, that's a scientific term, Hispanics, and also American Indians. And the first thing that I notice when I look at this is these bars are not equal. In fact, Native Americans in this state as a group have about half the risk of cancer as non-Hispanic whites, and in fact, as of most folks in the United States. Now, interestingly, this is kind of a unique phenomenon to the Southwest. If you were to look at Native groups up in the Midwest, in Alaska, in the Northern Plains, in the Pacific Northwest, these rates for Natives would be right up here, if not a little bit higher than non-Hispanic whites. But historically in New Mexico and Arizona in the Southwest, Native Americans have had lower rates. So you'll see that here in northern New Mexico, the rates for cancer are lower than they are for non-Hispanic whites. Okay? But don't get all warm and fuzzy about that, because we have some modest evidence from the last 50 or 100 years that there was actually less cancer among Native populations historically than we have today. So even though Natives have a lower risk of cancer today than non-Hispanic whites, it's quite possible that if we could have done this job 50 or 100 years ago, these rates might have been even lower here. And for many of the major cancers, we don't have time to go through this today, but for many of the major cancers, these rates have actually increased pretty dramatically for Native populations in the last 30 or 40 years. Probably has to do with a lot of things, changes in lifestyle, changes in diet, possibly environmental exposures. But the other thing that I noticed is that Hispanic populations also have slightly lower rates, probably about 2/3 of the rates of non-Hispanic whites. Okay? And again, there may be environmental things here that are different between these groups. It could be that 100 years ago, the Hispanics had quite a bit lower rates than they did today. But this is what things look like in the first decade of the new millennium. And for this reason, if somebody tries to sell you a county incidence rate, just talking about the county, without breaking it down into these three ethnic groups in northern New Mexico, they're lying to you, okay? Because if I took an average of this, and if I was in a county where half the population was Native American, you'd have really low incidence rates. Do you follow me? So it's the most honest thing to do is to come to you, and you should demand this of anybody who comes to you with health statistics that you know vary by race and ethnicity, for them to show you these rates by race and ethnicity. So I'm comparing Anglos to Anglos, Anglos in northern New Mexico to Anglos in the rest of the state, Hispanics in northern New Mexico to Hispanics in the rest of the state, and American Indians to, you guessed it, American Indians in the rest of the state. Okay, this is the most appropriate way to look at this. So coming back to this then, you can see that the rates for non-Hispanic whites are just about the same in northern New Mexico as they are elsewhere. If you get up close enough, I'm sorry for the folks in the back, but if you get up close enough, these rates are actually slightly lower in northern New Mexico, but from my perspective, they're virtually the same. Now, the other thing that is a little bit challenging to see, even I have to put my glasses on to see these, is these confidence intervals. They're very tight. We've got a lot of Anglos. This gives us a very precise measure of this incidence rate here. These incidence rates are very similar, and the confidence intervals are really, there's a lot of overlap here. So I would say that if we actually sat down and did a formal statistical test, we'd probably end up telling you there's no statistical difference between the rates here in northern New Mexico for non-Hispanic whites and those in other areas of the state. Same thing is really true for Hispanics, virtually identical rates here. These confidence intervals are very tight because we've got a large number of folks that we're looking at. Now look at the confidence intervals for the natives. There are fewer natives, so we have fewer cases to work with. The rate becomes a little bit less statistically stable, so I've got wider confidence intervals. I'm a little bit less confident about this measure, but still, it looks to me like the rates up here in northern New Mexico for the native populations are slightly higher than they are in the remaining counties. And even though I'm going to guess that these confidence intervals overlap a little bit, that's going to suggest to me that they probably aren't statistically significant differences here. I would probably want to come back and pay a little bit more close attention to this. I'm going to guess that even though I might not achieve statistical significance between these rates, it's going to be very close. So I might want to keep an eye on that and see whether or not I can further see what differences there are between these two groups. Okay, any questions so far on what I've shown? Yes, sir.
Don't give me a 5-minute question.
No.
Okay, I just need something short. I can't remember.
No,
I'm not one of these smart lab guys who can remember this.
Very simple. I take a little bit of difference with your bar on the crosshatch one. Other New Mexico Indians. How about all the Native Americans up in Shiprock and in Gallup and Farmington? I understand that there's a lot of Indians in that part of the country that have gotten the cancer due to mining uranium. So I don't understand why it's even lower than northern New Mexico. Because there's not that many American Indians working at the lab.
Well, so you have to keep in mind that this is Native Americans from all 3 counties, right? Or all 4 counties that we're looking at. The mining-related cancers that we know about in say, the Shiprock area and those areas, that phenomenon was well documented back when the uranium industry was booming back in the 1980s, back in the 1940s, 50s, 60s, 70s, and 80s. But the uranium industry hasn't been around in those areas. There hasn't been mining going on. Some of those rates are not quite as high. Some of the cancers that we're seeing that were related to uranium mining are probably not arising because of uranium mining any longer. We're actually involved in some research now. So I would say, looking at this, and I would be glad to entertain alternative explanations. To me, this isn't a huge difference. What I would really want to look at is individual cancer. So it might be more interesting if we looked at, for example, lung cancer. Lung cancer is one of those cancers that the Navajo suffered from. The folks who were mining in these family mines, no ventilation. And the lung cancer rates for that area might actually be quite a bit higher than here in northern New Mexico. If we looked at stomach cancer rates, they might be exactly the same. So I'm not disagreeing with you. I'm just saying that there might be other reasons why that came out the way it is. Okay, thank you. And if you want to talk more afterwards, let's do that. I can try to explain that a little bit more.
I have sort of a general epidemiological question. How do you deal with people who move? For example, I grew up maybe close to this New Jersey Cancer Alley, but then I've lived here for 10 years. So if I were diagnosed with cancer today, how would you tell if that's from a New Mexico exposure or from my earlier exposure? If I live in Los Alamos 10, 15 years, if I move away in a couple years and then later I get cancer, are they going to count my living in Los Alamos as having contributed to that, or will I count, wherever I happen to live at that point?
That's an excellent question. So if you didn't hear the question is, people move. If I look at these cancer rates today for this geographic area, how does that capture a person's exposure in the past? And it's particularly relevant to cancer because most cancers take 10, 15, 20, 30 years to happen. The answer is not from a study like this. Studies like this can give you some direction. If I saw high incidence rates of cancer in Los Alamos, that would be my first clue that there might be something there that we need to look at. But any epidemiologist would say you can't take a rate like this and infer absolutely just exactly for this reason that those rates in Los Alamos are due to some exposure in Los Alamos. So the way that an epidemiologist would do that would be to study a cancer, to interview people who've got that particular cancer and do exactly what you say. Take a history of their occupational history, their past, their residential history, and then compare histories among people who have cancer to people who don't have cancer to establish whether or not a residential exposure was important or an occupational exposure was important. So these types of things are useful for getting a lay of the land, but that's the first caveat that I would have to tell you in looking at data like this. I can't equate a higher or lower rate of cancer by a rate with necessarily with it. Now, if there was some big thing causing cancer in Los Alamos, and what would happen to the rate? Over time, that rate would go up. So if I did see a high rate in Los Alamos, it's possible that it is due to some exposure. But you've hit the nail on the head in terms of
of interpreting these rates. All they can really do is kind of give you a first pass or a first idea of what's going on. Yes?
I'm wondering how you account statistically for how often the population accesses medical services and actually reports cancers.
So cancer, most cancers, not all cancers, but most cancers are not the kind of things that you put off. You don't have a breast cancer or a pancreatic cancer or a lung cancer and hang around very long. Whether you've got insurance or not, you seek medical help. And so our coverage is not only in practices of people who see cancer, but there are pathology labs where the cancers are diagnosed, where the tissue is diagnosed. We have access to the death certificates where people die from a cancer. That comes in probably for every cancer case. We have between 5 and 10 sources that are independently abstracted and reported into the registry. You've hit the nail on the head for that's a lot of what the research we do is to look and see how people access care. Usually, though, it doesn't necessarily influence whether they get care or get diagnosed with cancer, but it might influence how well they're treated. It might influence other factors that have to do with the cancer-related care. But it doesn't often influence whether or not you are diagnosed with cancer or that your cancer is documented when you might die from the disease. Okay? So let me, before I take any questions, let me tell you this. We've run out of our time. Do you want me to just hang around and talk to you guys afterwards? Do you want me to go on for a couple of minutes? I don't know what the rules of your organization are. Go on. Okay, I'll tell you what I'll do. Let me give me another 10 minutes and I'll script through these slides. But I have one last question from this gentleman.
Yes, my doctor told me all males will eventually get prostate cancer as they grow older. And the older you get, the greater the possibility that you're going to have prostate cancer. And in fact, you could die from prostate cancer because they won't treat it after a certain time, because they say you're going to die of something. And prostate might be prostate cancer.
And I'm not sure that everyone would agree that every male will eventually get prostate cancer, but there clearly are studies where they took old guys, and once they kicked the bucket, they looked at their prostates. They looked at a bunch of old guys who died, looked at their prostates. They found prostate cancer in probably 80% of those guys. Right? Some of it's diagnosed, some of it's not. Prostate cancer has a broad spectrum of behaviors. Some of them are very benign, and you may have the disease, but you would never know it. And you'll die at 99, a happy camper of something else, right? Never knowing that you have prostate cancer. This is one of the interesting challenges about prostate-specific antigen, or the PSA test. We've now identified a bunch of men who heretofore never would have known that they even had prostate cancer, and it's our challenge to try to figure out whether you do something about it, you treat those or not. That's talk for another day. But that's correct. I think I would say, from what I've seen, most men, by the time they get into their 70s or 80s, probably have either prostate cancer or some sort of hyperplasia, something that's on its way towards being cancer. So this is another graph that's kind of hard to see, but let me show you what I did. So this is for non-Hispanic whites, and I've lined up all the counties in the state, from the highest rates in the state to the lowest rates in the state. I showed you in orange here, this dark bar, what the New Mexico statewide average is, and I've put our 4 target counties on here so you can get a sense of where your county is at. So Los Alamos and Santa Fe are right above the state average, slightly higher than the state average for non-Hispanic whites. Taos and Rio Arriba County are slightly lower than the state average. And so when you put all of these together, you get that graph that we just looked at, where together probably we're slightly lower risk in northern New Mexico, but I would say about the same risk as the statewide rates. Okay? So this is kind of an interesting graph to look at. It gives you a sense for where you're at if you live in one of these counties. Let's look at Hispanic data really quickly. So here's the statewide average. And here, 1, 2, 3, 4, 5, the 6th county up is Taos.
So Hispanics in Taos County have rates that are a little bit higher than the statewide average. Conversely, Santa Fe Hispanics are right about the same. They're a little bit lower numerically, but they're pretty much on par. Coming down here to Rio Arriba County, the Hispanic rates are a little bit less than the statewide rates. And Los Alamos Hispanics, both of them, no, just kidding. There's not a lot of, there's not a huge Hispanic population. That was a bad joke, but there's not a huge Hispanic population in Los Alamos. It's like 80% Anglo, if I remember my census statistics. But there's not a huge. The rate is slightly lower, not greatly lower, but a little bit less in Los Alamos Hispanics than the statewide. Okay. Together, though, when you put those together, I think those Hispanic rates were just about, when you average those out, they were just about the same as the rest of the counties together.
Sure.
Let's look at, yes, sir.
I live in Taos, so that means I need to move to Los Alamos.
That's right. See, that, correct interpretation. He just said he can lower his risk by moving to another county. That's absolutely correct. Not, but anyway. That's, so here's Native Americans, and this is interesting to me. Remember I said I want to take a closer look at that Native American data. And this would be my first step to a closer look. And so here's the statewide average for Native Americans. And all 4 of these counties have rates that are actually a little bit higher than the state average. So starting in Taos, or here Santa Fe is a little bit higher. Both of these are pretty close to the state average. But both Rio Arriba and Los Alamos natives are a little bit higher. And again, there's not a huge number, I don't believe, of Native Americans who actually live physically within Los Alamos County. But of those who do, their rates are a little bit higher up here than the statewide average. So this is another step to helping us to understand what the burden of this disease is here in northern New Mexico.
So Quake County was up there on top on all 4. Could you kind of elaborate on that, or all 3?
Not till I go to Quake County and talk to them. I don't know. I haven't actually looked at that. I will tell you, the other thing that I probably should stick on these things are those confidence limits, those bars. You would see that for more rural counties that are more sparsely populated, those rates, we have a lot less confidence about where that rate really lies. And Clay would probably fit that. But that's an interesting thing. I have seen that. I have not taken any steps to try to figure out what's going on in Clay County. So, but that is an interesting observation.
The same would apply with Catron County as well.
With Catron and those other ones as well, they're pretty high.
Yeah, they're not populous counties.
Yeah, they're not.
Exactly.
No, Catron is one of the least populous counties in the country. I think it's what the Census Bureau calls a frontier county. So, okay, well, I'm going to scoot on just quickly so that I can show you. There's several cancers that people are always asking me about, and I figured that you guys would too. And I'd love to come and show you. Maybe you'll invite me back sometime to talk to you about all the different kinds of cancers. But these are ones we get a lot of questions about. This is female breast cancer, the most common cancer in women. The rates in northern New Mexico are somewhat higher than they are in the rest of the state. Because these confidence bars don't overlap, this is a statistical excess of breast cancer. And I can tell you that if we looked at Los Alamos County, if we broke Los Alamos County out, their rates are actually quite a bit higher than the rest of the state. And we don't, I will tell you flat out, we don't know for sure why that is. I have some ideas that I'll share with you very quickly. The things that, if you asked me who the highest risk woman in the country was for breast cancer, based on studies that we've done, I'd have to say somebody who's of high socioeconomic status. A lot of times these women are white or Anglo, like me. And things that go along with that have to do with things like reproductive behavior. How many kids do you have? The more kids you have, every breast cancer study that's ever been done shows that having more kids puts you at lower risk for breast cancer. If you breastfeed, you get additional diminishing of risk. If you take exogenous hormones, postmenopausal hormones, in the old days when you used hormones for birth control, you increase your risk of cancer. These are things that probably well describe the Los Alamos population. These are women that are highly educated. Many of them are white. Many of them put off having children until later in life if they've had kids at all. They are the poster children for high-risk breast cancer. This is just the scientific facts. And it's not a great public health message because I'm not telling the women of the state to go out and get married when they're 12 years old and have 20 kids. That's not a reasonable message. I mean, it's silly. But the fact is that those are the risk factors that have come in study after study. Interestingly, if you compare Los Alamos to other counties that have similar demographics around the country, Marin County, California, Long Island, New York, a couple of counties that I can't remember in Connecticut, all of these counties have very similar breast cancer rates. None of those counties have nuclear facilities. So there may be environmental things going on up in Los Alamos, but I'll bet you at least a medium latte that there may be other factors that could contribute to the breast cancer risks in Los Alamos as well. Interestingly, though, a slightly higher risk of breast cancer in Hispanics. These confidence intervals don't overlap, so they're probably not statistically significant. A slightly lower risk of breast cancer in natives. And I really am going to try to finish shortly here. So colorectal cancer, not really on anybody's radar screen for radiation-related cancers, per Heidi's slide. So I thought I'd throw this in just to show you. Los Alamos actually has slightly lower rates of colorectal cancer, another quite common cancer, than the rest of the state. The Hispanics in northern New Mexico are probably bordering on a little bit higher, statistically higher rates of colorectal cancer than Hispanics in other parts of the state. Here's an interesting thing. If I showed this slide to you 20 years ago, Hispanics would have been down here. Over the last 20 years, the incidence rates for colorectal cancer in Hispanics have come up significantly, especially in men. They've now overtaken non-Hispanic whites, and we don't really know why that is. Finally, Native Americans here, this is a very broad confidence interval, but their rates are quite a bit higher than Native Americans in other parts of the state. And finally, the cancer we've all been waiting for, thyroid cancer. This graph says to me that it looks like the thyroid cancer incidence rates in northern New Mexico are a little bit higher than what I'd expect. And I'm also lying to you with this graph a little bit. I know that the Los Alamos rates are actually probably up around 25. So the rates of thyroid cancer in Los Alamos are actually probably at least double what they are in the rest of the state. Hispanics a little bit higher here, probably on the cusp of statistical significance. Native Americans higher. There is an interesting phenomenon, though, that we've noticed. Thyroid, two last tidbits, and then I'll shut up. Okay? So, and Andrew will come and tackle me with this hammer if I don't shut up. The thyroid cancer is going up in all of the developed countries of the world, and maybe even in some of the developing countries as well. There's a debate about what's going on. Is there really some environmental factor that's making these rates go up? Or are we doing a better job of detecting it? Okay? And so if you were doing a better job of detecting it, for example, with ultrasound or something like that, the paradigm would be that you would expect to see smaller and smaller tumors being diagnosed in more recent years because you can't detect, there are some tumors that you can't detect by palpating the thyroid, and there's some that you can. And in Los Alamos, exactly what we've seen in this decade of 2000 to 2009 is probably as many, a little bit more than half of these tumors that are being detected in Los Alamos are so small that they can't be detected by palpation. They have to be screening for this. This means that there are physicians in this area who are very much aware and very much looking for thyroid cancer. So my last anecdote of the day, true story, this just happened within the last month. I showed this slide to the medical students down at UNM. And I said, how many of you guys are from Los Alamos? And 4 students raised their hand. 4 out of 120 students raised their hand. And I said, do you guys, is there a lot of screening for thyroid? And they kind of said, yeah. I said, well, how many of you? You're all 20-something kids. How many of you have been screened for thyroid cancer? All 4 hands went up. All 4 of 20-something kids, you don't screen 20-something-year-old kids for thyroid cancer. All 4 of them had been screened for thyroid cancer. I said, okay, put your hands down. Of the rest of the 116 of you, how many have been screened for thyroid cancer? Not a single hand in the rest of the state. So adding these 2 pieces of information, we're seeing more very small cancers being diagnosed in this region of the state. We're seeing young people even being screened for thyroid cancer. I'd probably bet you maybe a large latte that at least some of the excess here is due to screening. Now, I'm not telling you that I don't think that there might be other factors, environmental factors, that could be going on as well. But I would be very surprised if at least part of this excess that we're seeing here isn't due to sort of a very enhanced effort to screen for this disease. Okay. Having said that, I'm going to shut up finally at long last. I probably shouldn't take any more questions, but I will stay around for a while. And so if you want to talk after the meeting, I'd be happy to answer these questions. Thanks for your patience.